Hi, I'm Larry Kestin, a radiation oncologist in Michigan. I am the medical director of the Michigan region for Genesis Care, uh, MHP Radiation Oncology Institute here in the Detroit metropolitan area. So in patients with brain metastases from non-small cell lung cancer, would you recommend upfront radiation treatment to the brain rather than systemic therapy with surveillance of intracranial disease? And when would you consider neurosurgical evaluation for resection? So first, let me discuss the surgery option. Surgery is usually only indicated for brain metastases when there is a solitary metastasis, especially a larger metastasis, or a situation where one is seeking a confirmation of pathologic diagnosis of the brain tumor, or a more urgent situation where removal of the tumor could relieve pressure or shift, or reduce the likelihood of herniation, or reduce the likelihood of long-term neurological sequelae. Other than those circumstances, usually radiation therapy alone for brain metastases is reasonable. Okay, so generally speaking, when giving radiation therapy for brain metastases, in the past, it has always typically been given up front prior to systemic therapy, because chemotherapy has been shown to have lesser penetration across the blood-brain barrier and lesser response rates in the brain. Now, today, certain targeted therapies, especially for EGFR or ALK, and even immunotherapy drugs, have been shown to cross the blood-brain barrier and elicit a good response in brain metastases in that setting without prior brain radiation treatment. So now this decision of whether to give the radiation treatment first or give the systemic therapy first, especially if it's a targeted agent, requires more clinical judgment. If the patient only has brain metastases or maybe has very minimal cancer involvement elsewhere, then certainly that's a situation where I would definitely lean toward upfront brain radiation treatment. Certainly if they're symptomatic from the brain metastases, that is a reason to push the radiation treatment earlier. On the other hand, if a patient has widespread metastatic disease with only some incidental brain metastases discovered that are asymptomatic, then one might be more inclined to offer the systemic therapy first, especially if it is a targeted or immunotherapy agent. Some other practical logistical issues can sometimes come into play. If we're waiting for second generation sequencing to be performed, which can take 7 to 10 days sometimes, and it is certainly reasonable to proceed with brain radiation treatment because it will be done in time for those results, would not cause any delays in the systemic therapy. Also, if the number and size of brain metastases allows us to quickly perform stereotactic radiosurgery, for example, then that could also be a situation where one might perform the brain radiation treatment early upfront. But this is not always there's not always a clear answer in this situation, and it requires multidisciplinary care discussion with your medical and radiation oncologist. If we're performing brain radiation treatment or even in the setting of, especially in the setting of surveillance, it's important to perform brain MRIs regularly to follow these patients, typically on the order of every 2 to 3 months.